Hello everyone, a very good morning to all. So welcome back to the 90-day crash course program. So today I'll be talking about the concepts in respiratory physiology. So in the morning session, I'll be discussing about the concepts of the previous year MCQs of NEET and INI-CET. In the evening, we are going to apply the concept. So in the morning, you get used to the concept, and in the evening, you just try to solve it with the help of the concept. Okay. So today, let's talk about the respiratory physiology. I will touch the basics as well as some core aspects of respiratory physiology. So we all know that the trachea leads to the bronchus. So the bronchus has bronchioles, which in turn has alveoli. So alveoli is very important because alveoli is a place where the gas exchange takes place, right? So there are four types of respiration basically. One is external respiration. So external respiration is the passage of the gas, that is the oxygen from the lungs and carbon dioxide from the bloodstream. So the passage of the gas between the bloodstream and the lungs, that is called as external respiration. There is something called as transport mechanism or transport respiration. So transport mechanism or transport respiration is the cardiovascular system and the lungs, they combine and they distribute the gas throughout the body. Okay, so that is transport mechanism or transport respiration. The third one is internal respiration. So internal respiration is the movement of the oxygen into the cells and the movement of carbon dioxide out of the cells. So the oxygen from the bloodstream moves into the cells and the carbon dioxide from the cells moves to the bloodstream. This is internal respiration. And there is something called as hypoventilation. To be specific, it is ventilation. It can be hypo or hyper. So ventilation is basically the passage of air into and out of the lungs. Just a broad term, into and out of the lungs. External respiration takes place between the bloodstream and the lungs. Transport mechanism distribute the gases throughout the body. Internal respiration takes place between the bloodstream and the cells. So the oxygen from the bloodstream enters the cells and carbon dioxide moves out. This is very basics. Okay. So with this basics, I'll tell you a very simple and a quick concept of what is called as respiratory acidosis and respiratory alkalosis. Okay, so we all know that the carbon dioxide has to move out of the lungs and oxygen has to come in. Okay, whatever the carbohydrates, the fats we take, it has more of carbon, hydrogen and oxygen. So this hydrogen is taken up and it is supplied to the electron transport chain where there is oxidative phosphorylation and their production of ATP. Meanwhile, this carbon and oxygen, they have to carry it through the bloodstream, they have to exhale. I don't want that carbon dioxide. Okay, so in the bloodstream, the carbon dioxide combines with water to form carbonic acid, and then the acid splits into hydrogen ions plus bicarbonate. Okay, so in the lungs, it has to reverse the situation, that is the bicarbonate and the hydrogen has to again reverse the reaction to form carbon dioxide. Okay, now what happens if the patient is having hyperventilation? What is hyperventilation? More amount of fast breathing takes place. Okay, so there is more amount of carbon dioxide moving out. So when there is more amount of carbon dioxide moving out, less amount of hydrogen is formed. So there is going to be respiratory alkalosis. What happens? There is hyperventilation. I'm just not quite well breathing and I'm holding the carbon dioxide within myself. So what happens? More amount of carbon dioxide, more amount of hydrogen ions, there is going to be respiratory acidosis. This is the very basics of respiratory acidosis and alkalosis. So most of the times, the carbon dioxide combining with the water is taken to the lungs and it is exhaled out. So in some situations, the body tries to hold it, and in some situations, it doesn't try to hold it, it exhales faster. So hypo and hyperventilation, respiratory acidosis and respiratory alkalosis. Right. So let us move into the lung volumes and lung capacities. Okay. Lung volumes and lung capacities. Okay. Now imagine a tide. Okay, so it slowly moves and it just moves on like that. So that is normal waves. So tidal volume, normal inspiration and expiration, normal inspiration expiration, it accounts to about zero point 0.5 liters. Okay, so tidal volume is 0.5 liters. On top of the tidal volume, if I am trying to inspire the air as much as I can, maximum inspiration after the tidal volume, it is called as inspiratory reserve volume. It is around 2.5 liters. On top of the tidal volume, if I'm trying to exhale, that is called as expiratory reserve volume. It's 1.5 liters. So on top of the tidal volume, the maximum inspiration I'm doing, that is inspiratory reserve volume. The maximum expiration I can do, that is called as expiratory reserve volume. It's around 1.5 liters. So we might think that the lung is empty, but actually it is not taking place. Some amount of residual volume of gas will be present in your lungs invariably, okay, whether you do IRB or ERB. Okay, so that is called as residual volume. That accounts to about 1.5 liters. So inspiratory reserve capacity, expiratory reserve capacity, residual volume and tidal volume. With these values, we can find out the capacities of the lungs. Okay, so as I told you, see, you have a tidal volume. Okay, it is around 0.5 liters. On top of the tidal volume, I can inspire maximum amount of air, that is inspiratory reserve volume. It is around 2.5 liters. On top of the tidal volume, I can expire as much as I can. It is expiratory reserve volume. It accounts to around 1.5 liters. And there is residual volume. It accounts about 1.5 liters. Right. So this is tidal volume. This is expiratory reserve volume. This is residual capacity or residual volume. And this is inspiratory reserve volume. So the combination of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume is called as the vital capacity. The combination of inspiratory reserve volume plus the tidal volume is inspiratory capacity. The combination of the expiratory reserve volume and the residual capacity or residual volume is functional residual capacity. Okay, it is called as functional residual capacity. And the entire thing, the combination of all the four, is total lung capacity. Now it looks simple, right? So this is the lung volumes and the capacities. Okay, so tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume. So the amount of air which is present after expiration. So the combination of the inspiratory reserve plus tidal volume plus expiratory reserve is the vital capacity, and there is combination of inspiratory reserve value plus the tidal volume is inspiratory capacity. Expiratory reserve volume plus the residual capacity is functional residual capacity, and the entire thing we call it as total lung capacity. Okay, so now imagine a patient comes with lung diseases. Okay, so we all know that there are two types. Either it can be obstructive or restrictive. Okay, so restrictive means, say for example, pulmonary fibrosis. Okay, so say for example pulmonary fibrosis, a patient comes to you with pulmonary fibrosis. What happens? The entire lung volume is reduced because it is fibrosed, right? So there will be decreased inspiration and decreased expiration, so all the four values will be reduced in case of restrictive diseases like pulmonary fibrosis, because the entire lung is fibrosed, it is stiff, the fibers are just constricting it, so it will be very difficult to inhale and exhale, so all the four will be reduced. They say for example in obstructive diseases, like whatever it may be, it can be a simple a sputum or COPD, whatever it may be. Here what happens is the inspiration will be normal, safe. Why? Because inspiration is an active mechanism. Okay, in case of a sputum or COPD or any narrowing of the, the vessel or the bronchus, what will happen is the inspiration will be normal as it is an active mechanism, but the expiration will be reduced. Why? Because expiration is a passive mechanism. So expiratory reserve volume and the residual volume will be reduced in case of obstructive diseases. In restrictive diseases, all the four will be reduced. In obstructive diseases, the expiratory reserve volume and the residual volume or residual capacity will be decreased, because inspiration is an active mechanism, expiration is a passive mechanism, and inspiration will be normal and expiration will be affected. So this is about lung volumes and lung capacities. Okay, so with this we'll see another one simple concept called as ventilation perfusion ratio. Okay, so ventilation perfusion ratio is basically, ventilation means we all know that it is air. Okay, so the amount of air taking place for the gaseous exchange is ventilation. Okay, so the amount of air that takes place during the gaseous exchange is ventilation, and perfusion is the quantity, the amount of blood which takes place in the gaseous exchange. So it's very simple. Alveoli present in the lungs, so there is exchange with the pulmonary artery. So oxygen moves in from the alveoli, carbon dioxide moves out from the pulmonary artery. This is a very basic mechanism, we all know. This is what we call it as ventilation perfusion ratio. It should be almost equal to 1. So actually if you see, the ventilation is around 4 liters and the perfusion is around 5 liters, so it is almost 0.8. It is equal to 1, so it should be almost equal. So what happens in some situations, the ventilation perfusion ratio, there will be mismatch. Say for example, in patients with airway obstruction or pneumonia or telectasis. Okay, so in patients with pneumonia or airway obstruction or telectasis, what happens is there will be no ventilation, there will be only perfusion. So in those situations, V by Q is equal to 0. What we call it as shunt. So ventilation perfusion ratio, when it is 0, we are going to call that as shunt. It is seen in patients with pneumonia or respiratory or airway obstruction or telectasis. So what happens? There is no ventilation, there is no gas, only the perfusion is there, the blood flow is there. Okay, in some situations like pulmonary embolism, the ventilation bar perfusion ratio will be infinity. So in these situations, there will be only dead space, which means there is more amount of ventilation and no no perfusion. So in this situation, no ventilation, perforation is present. Okay, so we have two. So when the ventilation a perfusion ratio is 0, we are going to call that as shunt. No ventilation, only perfusion. When the ventilation by perfusion is infinity, more dead space, increased ventilation, but there is no perfusion, seen in pulmonary embolism patients. So the most common cause of hypoxia will be this ventilation perfusion ratio mismatch. So this is another one small concept in respiratory physiology. So let's move into the final topic, that is the mechanism of breathing. Okay, so with the mechanism of breathing, the respiratory physiology previous year question concepts will come to an end. Okay, so the mechanism of breathing. Okay, now we all know that a small concept called as atmospheric pressure and intrapulmonary pressure. Okay, so whenever there is decrease in the pressure, the air moves in. So air moves from higher pressure to lower pressure. So there is something called as atmospheric pressure, which is approximately 760 mmHg. Okay, and also there is some pressure in the lungs, which is the intrapulmonary pressure. So this is called as parietal pleura, and this is visceral pleura. The parietal pleura and the visceral pleura as what is called as the pleural cavity. So the pressure inside the pleural cavity is intrapleural pressure. So intrapleural pressure will be 756 mmHg. Okay, and this area is the intrapulmonary pressure. Okay, so the intrapulmonary pressure is approximately 760 mmHg, which is equal to the atmospheric pressure. This is a very basic concept. Okay, so the intrapulmonary pressure is equal to the atmospheric pressure of 760 mmHg, but only when there is a low pressure the air will enter. When only when the atmospheric pressure is low, the air will come out of the lungs. So this is the basic mechanism. So we have the rib cage covering the lungs, and between the ribs we have what is called as the very important muscles, that is the intercostal muscles. Intercostal muscles, and also we have a muscle called diaphragm. Okay, so the diaphragm and the intercostal muscles, they play a very important role in inspiration and expiration. So what happens in inspiration is the diaphragm and the intercostal muscle contract. So because they constrict, the volume of the lungs increases. It becomes big. So because the volume increases, the pressure, that is the intrapulmonary pressure, drops by 1 mm. So it becomes 759 mmHg. Okay, so because the drop in pressure, the atmospheric pressure is more than the intrapulmonary pressure, so air comes inside the lungs. This is what is happening in inspiration. So the intercostal muscles and the diaphragm, they both contract, so the volume of the lung increases, so the intrapulmonary pressure drops by 1 mmHg, that is 759. So because of the drop in pressure, the air from the atmosphere comes inside the lungs. We all know that the air moves from the area of higher pressure to the lower pressure. Okay, so in expiration, vice versa takes place. The atmospheric pressure, what happens, the intrapulmonary pressure, it increases by 1 mm, that is it becomes 761 mmHg in expiration. Why? Because the diaphragm and the intercostal muscle, they relax, so the relaxation causes constriction, or the pressure inside the intrapulmonary area increases, so it is 761 mmHg. So because of the increase in the pressure, the air, it moves out of the lungs. So this is what is happening in inspiration and expiration. So this is the mechanism of breathing. So you apply all these concepts, the basics of all these concepts. These are all the concepts of the previous year questions which are asked in NEET, MDS and the INI-CET. So in the evening session, I'll be discussing about the previous year MCQs and also a few case scenario MCQs based on these concepts. So just be aware and have a quick revision of all these concepts. See you all in the evening session with the MCQ discussion, and have a nice day. Thank you so much.